A very good morning to all. On behalf of IIP Digital Media team and IIP Women's Cell Maharashtra, I welcome you all to this webinar on physiotherapy and non-cyclical chronic pelvic pain. We are streaming live on IIP India YouTube channel. I request everyone to subscribe to this channel to get regular notifications for our webinar. This webinar is being organized by IIP Women's Cell Aurangabad district of Maharashtra. The moderators for today are Dr. Ashwini Kale and Dr. Antara Deshmukh. So I request the moderators to take over.
Good morning, everyone. I'm Dr. Antara Deshmukh, District Sub-Coordinator of IIP Women's Cell for Aurangabad District. We have with us Dr. Ashwini Kale, District Coordinator, Dr. Vaibhavi Valimbe, District Sub-Coordinator for Aurangabad District. We will be host for today. IIP Women's Cell started on 30th May 2018. It functions under the guidance of National Head Dr. Ruchi Vaishne and IIP President Executive Dr. Sanjeev Jha. IIP Women's Cell works towards conducting public awareness camps, CME workshops. It aims at bringing together all physiotherapy professionals for sharing knowledge and improving public awareness about physiotherapy. We have 5 zones in India with heads for each. Dr. Pooja Kamre is the West Zone Head. The state team of IIP Women's Cell Maharashtra includes State Coordinator Dr. Suvarna Garne ma'am, Joint Coordinator Dr. Snehal Patel ma'am, and Sub-Coordinators Dr. Uttara Mohan, Dr. Priya Karande, and Dr. Nirali Sangvi ma'am. In Maharashtra, IIP Women's Cell has conducted more than 40 low-cost activity in various districts. In the first corporate IIP conference held in Indore in April 2019, Maharashtra State received award for the best state IIP Women's Cell. We shall now proceed for today's session. I would like to introduce our honorable speaker for today's Dr. Shalini Wiseman. She is a chartered physiotherapist in women's health and continence, is an expert practitioner and lecturer in obstetrics and urogynecology with over 17 years of experience. She is the clinical lead in women's health and continence at the Cork Women's Clinic. She is a member of the Pelvic Obstetric and Gynecology Physiotherapy UK and a member of the Chartered Physiotherapist in Women's Health and Continence Ireland. With 13 years of experience as a senior physiotherapist for the Cork University Maternity Hospital, she is also provided guest lecturer for the University College Cork for the MSc Obstetric and Gynecology Medical and the Midwifery modules. She completed her MSc by the research on the topic of the chronic pelvic pain over the years. She has presented at numerous nation and international conferences such as International Urogynecology Association Conference, European Urogynecology Association Conferences, Continence Foundation Ireland, and the International Continence Society Conference. I welcome you.
This has got a bit stuck. Hi, good morning. Can everyone hear me okay? Perfect. Before I begin, I'd like to thank IIP Aurangabad for this opportunity, and I'd like to thank Dr. Ashwini Kale for helping organize this. My name is Shalini Wiseman. I'm a chartered physiotherapist in women's health and continence, and I've done my research predominantly in chronic pelvic pain. I'm going to share my slides now. Okay, here we go. So chronic pelvic pain is one of the most complex conditions a women's health physiotherapist can treat, but it is also one of the most rewarding conditions a women's health physio can treat. It requires a good hold on pelvic anatomy, not just musculoskeletal and ligament part and pelvic floor part. You need to know about visceral anatomy, gastrointestinal anatomy, neural anatomy, and hormonal changes. 2 seconds. Here we go. Before we start, we need to know about types of pelvic floor dysfunctions, because many a times pelvic floor pain is overlooked for different dysfunctions, and those dysfunctions are considered to be the cause for chronic pelvic pain instead of looking at pain itself. Pelvic floor dysfunctions is never caused due to a single etiology. It's always different or multiple etiologies that causes pelvic floor dysfunctions. It can affect one or all compartments of your pelvic floor and can result in pelvic floor organ prolapse, such as a uterine prolapse, a bladder prolapse, or a rectal prolapse. It can cause bladder dysfunction, such as urinary incontinence, and voiding dysfunctions, such as overactive bladder, difficulty emptying bladder, or pain with emptying bladder. You can also have anorectal dysfunctions, such as fecal incontinence and fetalatus incontinence, that's difficulty controlling wind, and also voiding dysfunctions where the person can be constipated, have been straining, and have difficulty and pain opening their bowels. You can have vaginal and uterine dysfunctions, which can cause dyspareuria and or sexual function. And you can have pelvic floor pain and its referred pathway. Medically, we would look at the above dysfunctions I've mentioned, and pelvic floor pain dysfunction is omitted. Unluckily, this is the first thing that needs to be treated to rectify other pelvic floor dysfunctions. So before I start into chronic pelvic pain, we need to know what is pain. As per the International Association of the Study of Pain definition, pain is a sensory and emotional experience which can be caused due to an actual or potential tissue damage. The pain is subjective and is influenced by biological, psychological, and social factors. Unluckily, because there is an issue where there is a psychological and social factor influencing pain, we cannot be looking at pain just from a biomedical or biomechanical approach. We need a biopsychosocial approach of management for pain. With the biopsychosocial approach of management for pain, we need to know whether the pain is caused due to peripheral or segmental sensitization, where it's localized to an area, or is there central sensitization present. If there is central sensitization present, you do need to take a more biopsychosocial approach because this is driven by psychological and social factors. Unluckily, due to the lack of time, I will be looking more at the etiology and the biomedical and biomechanical approach from for chronic pelvic pain from a physiotherapy point of view. Why is a biopsychosocial approach needed? When you have pain, or pain over 3 months is classified as chronic pelvic pain or chronic pain. When you have pain for over 3 months, the person is going to have anxiety. That is then going to lead to fear. That is then going to increased pain because the person has fear with movements or fear doing things that would be considered very normal. That then is going to lead to catastrophizing of pain, which then is going to make the pain worse. So if you're only looking at pain, but you're not dealing with the patient's anxiety, fear, and catastrophization, and giving it a more psychosocial approach as well than just a biomechanical and a biomedical approach, you ain't going to change the person's ability to manage their pain. So from a biopsychosocial approach for physiotherapy, we need to be looking at assessment. In the assessment factor, you need to identify whether it's a tissue dysfunction, where there is segmental sensitization versus whether it's central sensitization. You then need to decide your management with regard to desensitization of pain. To reduce anxiety and fear, you need to do graded exposure to what they're fearful of and start them with graded mobility with regards to what they're fearful of doing, be it activities of daily living, or maybe it might be a simple thing of getting back to exercises that they like, and then teach them self-efficacy techniques in terms of managing their pain. And that would be your general approach you need to look at formulating for a chronic pelvic pain patient. So what is chronic pelvic pain? Chronic pelvic pain is classified into cyclical, mixed cyclical, and non-cyclical chronic pelvic pain. Many people will assume that chronic pelvic pain is just purely pain in your pelvis, but actually no. It involves pain in your pelvis and pain in your pelvic floor muscles. It can be present in men, women, and children, so it's not exclusively for women. Cyclical pelvic pain, however, is for women. This is due to gynecological or hormonal issues, and you need to have a gynecological investigation to rule out cyclical pain. Cyclical chronic pelvic pain is related to hormonal changes, and generally the pain increases around the time of ovulation or around the time of menstruation cycle and eases after. Mixed cyclical chronic pelvic pain is much more different. This too requires investigations, and they might need to be put on some sort of an oral contraceptive to balance out their pain. Their pain can be constant, which then worsens around the time of ovulation or menstruation and then decreases after. Non-cyclical chronic pelvic pain is not related to hormone or any gynecology pathology. It is purely a localized pain which can be from different etiologies other than gynecological or hormonal issues. This pain does not change with hormonal changes. It remains equal right throughout. So the woman can particularly complain of pain right through, and it might be related to certain activities, but it's not influenced by any hormonal changes. So what are the symptoms for non-cyclical chronic pelvic pain? Some of the few symptoms that you would see with non-cyclical chronic pelvic pain is dyspareuria, which is pain related to intercourse, dysgeusia, which is pain related to opening the bowel, dysuria, which is pain on urination, suprapubic pain, lower abdomen pain, painful pelvic musculature, so they can be misdiagnosed many times that they have just pelvic girdle pain per se, and pelvic floor is not reviewed. And they can also have worsening of pain after pelvic floor related activities, such as loading on the pelvic floor when you're sitting or wearing a tampon. With dysuria, you would find many of these patients are constantly sent for urinary tract infection. They come back with negative urinary tract infection tests, but they're still treated with UTI, and never is pelvic floor looked as an issue that is causing pain with urination. So what's the challenges in diagnosis? In female chronic pelvic pain, it's a multisystemic disorder. The symptoms can arise from musculoskeletal, neurological, urogynecological, gastrointestinal, or the endocrine system. Chronic pelvic pain can also be triggered by many factors such as behavior and psychological factors. What research has found is that 15% of women who were surveyed with chronic pelvic pain had poorer general health. These women complained more of fibromyalgia pain along with their chronic pelvic pain. They had a greater number of them reported a chronic fatigue syndrome and IBS, and they also had a greater number of women reporting depression, the ones who suffered chronic pelvic pain. You do require to understand an in-depth understanding of which system is contributing to chronic pelvic pain, and you need to know the referral area. And the biggest thing you need to know is you need to be able to differentiate between pelvic pain, dyspareuria symptoms, urogynecological symptoms, and sexual dysfunction. So it's actually quite a broad umbrella that we're classifying all this under as non-cyclical chronic pelvic pain. And you also need an MDT review. If you are a physiotherapist who is treating chronic pelvic pain patient, having a multidisciplinary team with you is crucial. So on your team, you should have a urogynecologist, a gynecologist, pain specialist, colorectal surgeon, and a psychologist if possible. So here's a case study, and this will give you an idea of what a chronic pelvic pain, non-cyclical chronic pelvic pain looks like. So you have a 26-year-old nulliparous woman, so obviously she's not had any obstetric history, referred to her obs and gynae with the following symptoms. She has pain with prolonged sitting and exacerbated low back pain radiating to the right and left buttock and left pubic region, with left lower abdomen and left inner thigh. Her visual analog scale for pain is 6/10, and it's a constant. Her MRI is normal. She takes part in high activity levels with rigorous abdominal exercise. She has a sitting job which requires frequent standing breaks. The reason she was referred to her OBGYN is because she had developed strong urgency and frequency with urination. She also had pain when opening her bowels, where she went from going once a day to going 2 to 3 times a week, though she had an excellent diet and an exercise regime. She had high levels of pain with intercourse leading to avoidance. The impact on her social life and personal life was minimal. There was no history of trauma or sexual abuse. The gynecology reviewed her with a vaginal examination, scan of her lower abdomen, frequency volume chart to look at her bladder intake, and she was referred for physio with a date scheduled for investigations. Her symptoms were not exclusive to menstrual cycle or did not worsen around the time of her menstrual cycle. A case like this seen by a MSK physio would have only looked at the back because of the exacerbated pain in and low back, and would have never questioned about her pelvic floor issues. If you haven't treated her pelvic floor issues, her back wouldn't resolve because a lot of this pain is actually coming from the pelvic floor region. Hence, addressing bladder, bowel, and sexual function in your MSK uptake is actually useful because it might help you tie in the picture more correctly. Similarly, if she had only gone to a women's health physio who only looked at her bladder and bowel function and her pelvic floor pain function and didn't actually address her low back, that wouldn't be resolved either because the pain in her pelvis would have slowly fed back into her pelvic floor, causing her symptoms to come back. You also need to look at her lifestyle factors, which might tell you whether this is perpetuating her non-cyclical pelvic pain. So if you have to consider a physiotherapy review, where you're looking at the contributors for pelvic and pelvic floor pain, you need to be able to differentiate whether there are urogynecological symptoms, gynecological symptoms, gastrointestinal, neurological, dermatology symptoms. Is it lifestyle related, such as sporting activities? And are there social influencers and psychological influencers? And that's very, very important to rule out. Many a times, you might find it is the musculoskeletal symptoms that is actually aggravating your urogynecological, neurological, or gastrointestinal symptoms. You might also find that it is actually your gynecological symptoms that is then firing up your musculoskeletal pain symptoms. So it is quite difficult to pinpoint and say, this is your primary cause, this is your secondary cause. And the way I would say it is that because your bladder, your bowels, your small intestine, your uterus, your pelvic floors, and the pelvis are all compressed into one small compartment, one symptom feeds off the other. So if you have a fire in your house, there will be smoke in the other. So finding out where exactly the fire is crucial. Now, Jantos et al. Did pain mapping, and he looked at patients with bladder pain syndrome and vulvodynia. Both of these are fairly non-cyclical chronic pelvic pain, and he compared it with a non-symptomatic control. And what he found is that the highest reported pain region in the anatomy was the levator ani, which is your pelvic floor muscle, and your other pelvic muscles, which were your obturator, which were your quadratus lumborum, your piriformis, your gluteus medius, and adductor complex, compared to any other part of the body. So if you just looked at other pelvic floor muscles and you did not examine levator ani, you might have missed out their urogynecological symptom, which is their bladder pain syndrome, and their gynecological syndrome, which is their vulvodynia. So we're going to talk about musculoskeletal involvement and see how your musculoskeletal involvement could potentially contribute to urogynecological gastrointestinal systems, okay? We're going to start with the pubic joint. So pubic joint is a secondary cartilage which attaches anteriorly to the ilium. It is innervated by the branch of the iliohypogastric, ilioinguinal, and the pudendal nerve. It loads our weight. So there is an increased activity that with increased activity, there can be a lot of shearing force that can take place. It is important to note that behind your pubis rests your bladder and your urethra. So any excessive shearing force of your pubic bone can actually irritate your bladder and your urethra. It's also important to know that the superficial pelvic floor muscles, especially your ischiocavernosus and sphincter urethric muscles, are attached under your pubic bone. Your pubococcygeus and puborectalis is also attached under your pubic bone. So if you have any issues with your pubic bone, that can then feed into your urethra and bladder and cause you a lot of urgency, frequency, and pain. And it can also cause you pain with the sex, which is called dyspareuria. So it has been proven by Soja et al. That shearing of the pubis can cause very specific clitoral or genital pain due to the innervation of the pudendal nerve. So if you have someone who's complaining of pubic pain, asking the question with regard to urogynecological issues with bladder might lead you into the pelvic floor nicely, and that might be also help you sort out the problem. The second concept you need to look for as an influencer is your lumbosacral, coccyx, and hip complex. With regards to the hip, we all know that the obturator externus is a stabilizing muscle of your hip, which comes from your greater trochanter, and it comes up to your ischial tuberosity. At the ischial tuberosity, the obturator externus turns into obturator internus and goes inside your hip to coat along the line of your pelvis, as is shown in the picture, to form the inner part of your pelvic floor called the obturator internus. Many a times, hip issues such as a labral tear can affect the obturator internus, which then gets attached to the inside of your pelvic floor and is related to a lot of the larger pelvic floor muscles, and it can cause pain with sex or pain with intercourse, and this is omitted many a times. It can also cause certain amount of pudendal nerve compression, especially if there's a patient who's had a total hip replacement. Sacrum now, with regards to sacrum, give me 2 seconds. The sacrum closes at the ilium by ligaments, and there's a form and forced closure. The sacroiliac joint can be affected due to hypermobility, excessive straining, laxity of the structure with pregnancy, and increased activities such as gymnastics. And that can be a potential cause of pain. You also need to remember that the empty rectum rests on the anterior surface of your sacrum and coccyx. It ends superiorly to your pelvic floor muscles at the anorectal junction. So this should be considered a source of pain if you have bowel issues, looking at the sacrococcyx complex. You also need to remember the proximity of the SIJ and the lumbosacral plexus to the sigmoid, colon, and rectum, and it should be considered as a potential source of pain or pressure. So many a times, it can be coming from lumbosacral and coccyx junction that's causing pain with regards to your sigmoid, colon, and rectal function. So there is an association with pelvic girdle pain and high tone pelvic floor muscles. If you are only going to be considering your pelvic girdle pain and not addressing pelvic floor dysfunctions, bladder or bowel dysfunctions, and sexual dysfunctions such as dyspareuria, you ain't looking at a patient holistically. Many a times I get patients who are seen by musculoskeletal physios, and then they're passed on to me to review their pelvic floor functions, and that works well too. If you can look at both, that's very, very good. With regards to pelvic girdle pain, the association with pelvic girdle pain and pelvic floor dysfunction or high tone pelvic floor muscle is much more, is coming into awareness a lot more now. What they've found is that the size of the hiatus together with high BMI is significantly associated with pelvic girdle pain. Bridget Stude et al. Looked at over 28 women and found that women with pelvic girdle pain had significantly smaller levator hiatus area, and they had a higher resting tone in their pelvic floor muscle than the control group, which didn't have pelvic girdle pain. We also know that high tone or hypertonicity in any muscle has significantly more nociceptive tender points, which can cause myofascial pelvic pain. So if you have pelvic girdle pain, the chances are you have a higher resting tone pelvic floor muscle, which can then have nociceptive tender points, causing you issues with your bladder and bowel function and dyspareuria. So what are the key muscles that cause pain in your pelvic floors? The key muscles that can be involved is coccygeus, piriformis on the outside and the inside of your pelvis, obturator internus, your levator ani complex, but superficial pelvic floors that are found along your pubic rami and your urogenital diaphragm can also have tender points because of its attachment along the pubic rami and pubis, and they can also contribute to pelvic floor issues. What are the symptoms you would see with pelvic floor pain? You can have stinging, burning, you can have increased frequency and urgency, you can have difficulty emptying your bladder, you might have pain while you're passing urine or while the bladder is filling, you can have pain while opening your bowels, and you can also have dyspareuria, which is pain with intercourse, or superficial dyspareuria, which is just pain with penetration. So what do we need to look at? When you are assessing for myofascial tender points in your pelvic floor, to rule out involvement of your pelvic floor along with your pelvic girdle pain, you do need to look at your pelvic floor muscles in two angles. Pelvic floor muscles are divided as superficial and deep pelvic floors. To assess the superficial pelvic floors, it's along the vertical clock face direction. So imagine a clock which is vertical, and you're looking at pelvic floors from 6 o'clock all along 12 o'clock. You're starting with your perineal body at 6, and you're moving along and looking at bulbospongiosis, ischiocavenosus, and sphincteruric muscles all the way along just under 12 o'clock. And you're seeing, are there any tender points? Is the muscle shortened and tightened? Is that actually reproducing or increasing her bladder or bowel symptoms? And releasing those muscles makes a huge difference. Generally, to assess muscles which are superficial, you need to do a vaginal palpation, and you will find the superficial muscles all along from perineal body, all along your pubic rami, and the insertion of the finger will be up to your second digit of your index finger, second phalanx of your index finger. When you go in further, you're going into your deep muscles, and you're going and looking all along your levator ani complex, your obturator internus, ilio and ischiococcygis, and piriformis right up on the inside, if you can reach it, to see if there's any tender points, and is it very sore on palpation, and you're trying to release the muscles, and that can again help in terms of relaxing your pelvic floors. Neural involvement in chronic pelvic pain is highly omitted. A lot of times these people are taken for injections and nerve ablations and epidural blocks without actually knowing which is the nerve that's affecting them. The injections and nerve ablations are done along the lumbosacral plexus without reviewing other nerves that could be involved. Iliohypogastric nerve is the most common nerve for entrapment, especially post-surgery. Post-surgery, it can get entrapped and give pain along the lower abdomen and in the pelvic region. This can be due to suture ligations, fibroid entrapment, or post-operative scars in the abdominal region. Signs and symptoms tend to be a pulling sensation with movement in the abdomen and pelvic region and throbbing at rest. You also need to be able to differentiate a neural diagnosis because it need not exclusively be iliohypogastric. It can be ilioinguinal or genitofemoral nerve because of the overlapping innervation. If you Google the innervation of iliohypogastric, ilioinguinal, and genitofemoral nerve, it'll give you a better understanding of the nerve pathway, and then you can see the correlation and see, is it purely lumbosacral plexus that's giving this issue, or is it actually the surgical entrapment that's going on? The most common neuralgia that is found with non-cyclical chronic pelvic pain is pudendal neuralgia. Pudendal nerve, the causes for is obstetric history. So if you have a high forceps with rotation, there can be certain amount of pudendal nerve damage that can be done. RTA, so road traffic accident, prolonged sitting. Long distance cyclists actually complain of pudendal neuralgia a fair bit. 2% of total hip replacement patients can wake up off the surgical table with pudendal neuralgia and complain of pelvic floor pain because of the extended traction and abduction that takes place in the leg while doing the hip replacement. With pudendal neuralgia, you need to rule off piriformis syndrome. But to classify it as a pudendal neuralgia, you need to look for the Nantes sign. So the Nantes criteria, the Nantes 4 signs that you need to look for is pain in the territory of the pudendal nerve, which is anus to clitoris or anus to penis. There is predominant pain experienced while sitting because of the compression of the nerve at the ischial tuberosity, but there is relief when you stand or sit on a soft cushion, and they also get a lot of relief when they sit on a toilet seat because there is no compression taking place at the pelvic floor and at the ischial tuberosity. The pain usually does not wake them up at the night, so they actually do get good sleep, which is a blessing, and the pain is relieved with a diagnostic pudental nerve block. All of Nante's criteria is indispensable for diagnosis of pudental neuralgia, but many times, because of a very traumatic obstetric history, the patient might complain of pelvic floor pain as well, will complain of pelvic floor pain as well, and it might not be entirely pudental neuralgia. It could be that the muscles in your pelvic floor, especially your obturator internus and some amount of your ischio-coccygeus and levator ana, might be quite tight, and compressing the nerve and releasing the muscle and stretching the muscle out actually helps take the pressure of the nerve, and that might take that pudental neuralgia-like pain away. However, irrespective of any amount of physio, if this isn't working out, getting them to see a pain specialist, getting the nerve blocked and seeing if that relieves it might indicate their outcome. The other two confusions that occurs is posterior cutaneous nerve and cluneal inferior nerve. Posterior cutaneous nerve and cluneal inferior nerve is often diagnosed as pudental pain, but pain from these two nerves is more inferior and medial. They also complain of somatic pain along the gluteal region. There is increased pain with sitting or sitting on a soft surface, and the pain is not relieved by standing, okay? There can be also piriformis pain with these guys, and there's an ischio-perineal radiation from these nerves, unlike what you would see with a pudental nerve, which is more along anus to clitoris direction, okay? It can be unilateral, so you might find that the pain is only on one side, and that it can go right under the gluteal fold and upward to the groin region. And they respond very well to a nerve block at the sacrospinous ligament and ischial block. They do not respond to a pudental nerve block. So knowing the difference can actually prevent a patient getting unnecessary injections. So to summarize, so that there is no confusion between pudental neuralgia and posterior cutaneous nerve and inferior cluneal nerve neuralgia, these guys will not get relief when they go from sit to stand because taking pressure off still doesn't affect. Whereas with pudental neuralgia, they get a lot of relief when they stand or when they're sitting in a toilet seat where there is no compression on the pelvic floor and the ischial tuberosity. And that's one of the biggest tellers. And with pudental neuralgia, you'll also find is that their pelvic floors can be very sore and affected. You need to look at urology and gastroenterology symptoms. Remember in the beginning, I said with non-cyclical chronic pelvic pain, you can have fire in one house and smoke in the other. You need to kind of find out what's what. Many times, gastroenterology and urology symptoms go hand in hand, which then causes the person to have pelvic girdle pain, lower abdomen pain, and pelvic floor pain. Hence, addressing urogynecology and gastrointestinal symptoms are very, very important. What we have, and sending them for investigation is very important. What we have found with research is that painful bladder syndrome and IBS tend to go hand in hand, and one feeds off the other. So if they have increased IBS symptoms, they actually have more painful bladder symptoms where they have pain with urination, pain on filling of the bladder, and they need to go constantly to the toilet along with other pelvic floor pain issues. They also have higher somaticization, which coexist with IBS and painful bladder symptoms. You need to rule out as a physiotherapist pelvic girdle and pelvic floor involvement. And if you find that there is no pelvic floor pain and there is no pelvic girdle involvement of the muscles, you need to get them to follow a bladder-friendly diet. You might need to send them for investigations by a urogynecologist and a gastroenterologist. With people with IBS, a FODMAP diet is recommended, and that is prescribed by a dietitian. So referring to a dietitian makes a huge difference. If you have patients with bladder pain syndrome, I would recommend the website called icrelief.com. It gives you a lot of lifestyle advice, which is very, very useful to follow. Lifestyle activities are the second thing that can cause pelvic floor pain. So sports-related activities is important to review. What has been found is that cyclists and heavyweight trainers tend to report more urgencies, traguria, which is difficulty urinating, dysuria, which is pain with urination, and penetrative dyspareuria. Whereas with runners, it tends to be more urgency and stress incontinence. So looking at their sporting activities or asking them if they've started any new sports can actually give you a better idea of these symptoms being more sports related or lifestyle related than being urogynecology or gynecology related, and sending them down a line of whole investigations. And if you know it's sports related, reviewing their pelvic floor, looking for muscle shortness or hypertonicity or overactivity of the muscle and helping ease that out might take their symptoms away, and giving them correct advice with regards to sports and weight training and looking at their breath holding and stuff will make a huge difference than them going and getting a whole pile of antibiotics and whole pile of urogynecology investigations done, which shows nothing. The other factors you need to look is of viscerogenic origin. Mobility of your uterus, your bladder, your small intestines can affect the muscles around. This can be impacted with childbirth, trauma, post-op scars. So looking and seeing how does the uterus move, how does the feel of the urethra, how is the feel of the small intestine can actually help if you know how to do visceral mobilization of your pelvic organs. You also need to look at bad habits. Women have a bad habit of constantly keeping their abdomen held, so they end up with overactive internal obliques and have high core rigidity, which then causes increased intra-abdominal pressure on your pelvic floor muscles, which then causes the muscles to get more tight and short in your pelvic floor muscles, causing you pain with intercourse, bladder and bowel pain problems. You also have butt clenchers, and this has been proven by research that women who tend to constantly clench their bum together to make themselves more smaller tend to have a higher pelvic floor resting tone, and they have a tendency to develop more active tender points in their pelvic floor muscles. So my advice to you ladies is let it all go, let it hang, because you're actually doing your pelvic floor health and your pelvic health a big favor. Don't constantly be pulling in your tummy, and there's no need to be constantly clenching your pelvic floors and butt together. The second is paradoxical breather and apical breathers. Type A personalities tend to be paradoxical breathers and apical breathers, and they can have a lot of pelvic floor issues because of constantly doing apical breathing instead of diaphragmatic breathing and the change in intra-abdominal pressure. These breathers are also seen in chronic coughers, which we might now see in a year's time with our COVID patients, cystic fibrosis patients and COPD patients. So they can also have pelvic floor affection. So it need not entirely be related to women. Chronic pelvic pain will be presented by children who have chronic coughers, like asthma patients. Coming down the line, maybe even our COVID patients. Men who have COPDs and smokers can have issues with their pelvic floors as well. So we need to be able to differentiate between chronic pelvic pain that is coming from a pelvic pain direction, then chronic pelvic pain, which is influencing urogynecology, or urogynecology that's influencing pelvic floor muscle symptoms. So if you have someone who comes with pelvic pain, they might complain of low backache, but they will have referred pain from the abdomen, adductors, and the pectineus muscle. Their pelvic floor will be affected, where there will be localized tenderness of the pelvic floor on palpation, presence of taut bands, where when you go along the pelvic floor muscles, you might find that there is a twitch reflex, and you can reproduce that acute pain under pressure. And when you get them to do a pelvic contraction, there is limited caudal movement where the pelvic floor moves up, but it doesn't let go and come back down to a resting tone. It stays up, and the relaxation is much more slower. And that's what is seen with just pelvic pain issues that is contributing to pelvic floor pain. However, if you have got urogynecological symptoms associated with pelvic floor myofascial pain, you will have some affection to bladder and bowel functions, such as increased urgency and frequency with your bladder, urinary hesitation, so difficulty starting to pass water, pain with or after urination, difficulty or painful defecation, where they find it quite difficult and quite painful to open their bowels. They might have pain during examination, and they will report of dyspareuria with their pelvic floors. They might also report of pain with wearing tampons, and this can be associated with episiotomy scar, painful bladder syndrome. Stress incontinence can actually cause pelvic floor muscle pain because they're so scared of leaking, they constantly clench their pelvic floors. And if we give these women only exercises to cure their stress incontinence and not address their pain issue, you're never going to get the pelvic floor to come back to normal, and they're just going to make their symptoms worse. So you actually need to reduce their tone, bring the pain down, and then look at very gently starting pelvic floor exercises, not the other way around. So asking the question about pelvic floor pain and symptoms is important. Lichen's complex is a dermatology issue. Google it and see. It causes a lot of pelvic floor issue as well, and they do very well with physiotherapy, especially manual physiotherapy for the pelvic floors. You can have urogynecological symptoms associated with vulvodynia, prostatitis, IBS, and post-IVF treatment. So asking about pelvic floor pain, along with your low back pain and urogynecology and bladder and bowel symptoms, is very important. Now, where's my thing going? Sorry. So what does physiotherapy treatment entail? With physiotherapy treatment for chronic pelvic pain, it entails intravaginal, intrarectal, and pelvic myofascial tender point release and trigger point dry needling. You might have to get the patient to stretch the muscle out because the muscle has got really tight and the introsi has got very tight. So you might need to do distension of the pelvic floor muscles either manually or with a therapeutic device such as a dilator. Global therapeutic massage and nerve mobilization and stretching does work for people with a lot of neural issues like pedental neuralgia or iliohypogastric entrapment. Visceral and fascial mobilization of the pelvic structure is also very useful. If you are going to your doctors and saying that I want to be part of the chronic pelvic pain team, many of the doctors need research to say why physiotherapy works. A lot of these patients are looked at for other pelvic floor symptoms. Their pain is never addressed. They are sent for nerve conduction studies unnecessary because it's a muscle that's impeding the nerve, but doctors don't look at muscles. They might even be sent for hysterectomy, saying that it's actually a prolapse causing you all this pain symptoms. An unnecessary hysterectomy is done, which could have been prevented if they were sent to a pelvic health PT who looked at their pelvic floor and were able to sort out their pelvic muscle pain, and that would have resolved it without them sending surgery. If you want to be part of a multidisciplinary team and say, hang on a second, I can actually help patients with this condition, or at least try physio before you go into more an investigation or a surgical approach, giving your literature helps. So there were 6 RCTs done with regards to physiotherapy for chronic pelvic pain. With regards to treatment duration, this takes time. It is not a 2 to 3 session miracle that we get. When we looked at the treatment duration among the 6 RCTs for manual therapy, what we found is it took about 7.3 weeks to over 24 weeks of treatment to get up to or greater than 50% improvement. Dyspareuria, pain with intercourse, was evaluated in 3 studies, and this is very interesting. Zober et al. Study found that 70% of the participants had statistical improvement in pain with manual therapy or physiotherapy compared to those that had injection therapy to their pelvic floor. There was statistically significant improvement for those who had manual therapy for their pelvic floor than injection. Heyman et al. Found that there was statistically significant improvement for dyspareuria for those who had manual therapy with 4 to 6 sessions of manual therapy compared to counseling group. And the number of patients who complain of dyspareuria are sent for counseling rather than physiotherapy needs to be considered here. What was found by Fitzgerald et al. When she looked at painful bladder syndrome and she evaluated 2 different types of physiotherapy technique, that there was actually no difference between the 2 treatments. Both treatments had good enough outcomes. Here are the cohort studies that's done. So if you want to take and go with your consultant, say, we can make a difference, this is what you need to take. It requires over 12 treatments or longer duration, but these studies looked at different in different chronic pelvic pain conditions such as overactive bladder, interstitial cystitis, dyspareuria, vulvodynias, chronic pelvic pain in men and women, and they reported 70 to 83% improvement, reduction in pain medication, improved global improvement scales, and the greater change in the whole psychology of treatment. So we do work. Here's your report if you need to take it and go and tell your consultants that these other patients we need to see before you send them down the line of investigation. Now, dyspareuria and sexual dysfunction, they're not one and the same. Many a times we assume that sexual dysfunction and dyspareuria are the same. No. Sexual dysfunction can be anything from loss of libido. They cannot be clumped in together. They need to be addressed together sometimes, but they also need to be seen separately. Dyspareuria can be pain with sex. Many a times, patients with sexual dysfunction see counselors just for dyspareuria, where physiotherapy would have been far more useful because it's to do with pelvic floor muscles and pain in the pelvic floor muscles, nothing to do with the psychology. So being associated with a counselor helps, but also educating the counselor that if they're only complaining of pain with intercourse, it can be pelvic floor related and might be worthwhile seeing a physio before they go for counseling. If the patient has no history of trauma or sexual abuse, they should be first seen by a physiotherapist and then in conjunction with a psychosexual counselor if required. However, dyspareuria if it cannot be resolved, if you find that you have done a lot of work and it's not changing, then you might need a multidisciplinary approach where you might need psychosexual counselors, but you also might need to see whether is it due to any issues with a birth trauma, or is it due to surgery or a nerve entrapment, and might be sending them down the route of the doctors for pain management. One of the biggest things we find with dyspareuria is 50% of the dyspareuria in women is not just women. 50% of women with dyspareuria, it involves their partners. So asking them the question with regard to their partners, men can have issues too, such as Peyronie's disease or hard flaccid, which can then cause women pain with sex. So treating women for dyspareuria and pelvic floor dysfunctions is a waste of time if their partners have an issue. So it's actually really important that you address this somewhere along the treatment, and you will find a whole lot of story can come up, which can actually guide your treatment a lot better in terms of a multidisciplinary approach. Now, this is where physios can be useful in terms of biomechanics of sex. If you have a patient who has obturator internis pain after a hip replacement, and you get them, if they go back into the activities of daily living and attempt a certain position, the chances are they could fire up the obturator internis again because of maybe say the hip replacement and the position that they've taken is not suitable. So getting creative and advising them with regards to positions that is comfortable for them is useful. Again, if you have someone who has a massive episiotomy and you're finding that certain positions might not suit them, advising them with regards to the positions makes a huge difference. You also need to look at partners' influence and lifestyle. Many a times it can be coming from the partner, so addressing that can make a huge difference. Partner's lifestyle can make a huge difference too, because the quality of the semen makes a huge difference. Men who smoke or drink a lot or have a high carbohydrate diet can have a more acidic semen than an alkaline semen, which then can irritate their partner and cause issues like thrush and vulvodynia. So addressing, and then that can cause pelvic floor pain. So addressing the lifestyle issues around partners can influence a woman's health much better. Hormones is the second issue. Women over 45 can have issues with regards to lubrication because of lack of hormones. So getting their doctor to put them on estrogen therapy, so getting them to use an estrogen cream can actually have huge benefits in terms of improving their vulvovaginal health for intercourse, and that does help a huge amount in taking care of the pain in your pelvic floor muscles. The type of lubrication used is also important. What do they require? Do they require a water-based lubricant, an oil-based lubricant, or a silicone-based lubricant? And considering that is important. Women who've had cancer chemotherapy because of the change in their pelvic floor muscles, because of the chemotherapy, especially breast cancer, a silicone-based lubricant is far useful than just an ordinary KY gel, which will be of no use at all. Anticipation of pain, and this is where your biopsychosocial model comes in, looking at anxiety and fear and giving them self-efficacy methods with regards to breathing, getting them to do more diaphragmatic breathing is actually useful to get them to learn to deal with their pain and anxiety. And you do need to address that at some stage with the patients so that you allow them to get over that anxiety and fear and they stop doing that whole perpetuation of the pain cycle. Dilators is an important thing, but you need to know what type of dilators to use. For someone who has a complete constricture of the introsa, you need to get them to increase their girth. Using the dilators of different sizes to allow for girth increase is useful. But if someone just has pelvic floor pain and you want to give them self-efficacy of managing themselves, using a TheraWand, which is the glass wand in the picture, to release their muscles along the vertical and horizontal clock by themselves is far more useful than just giving them dilators, because the dilators can be used only to increase girth and to some extent stretching, but it doesn't really release tender points, which the TheraWand can do effectively. Second is visualization technique. And again, this comes back to your whole biopsychosocial approach of treatment. If a patient has a lot of anxiety, anxiety is driven by the limbic system in our brain, which then is also related to pain because they're together. The anxiety and pain aspect is in the limbic system in our brain, and it tends to be together. So anxiety increases pain. However, if you get the other part of your brain, which is more frontal and related to visualization and creativity, that helps in terms of relaxing pelvic floor. So one of the ones I like to give in terms of visualization is to imagine there is an ice cream in your pelvic floor muscles, right up in your pelvic floor, and it might be something like a mint ice cream, and you just imagine that melting, and as it's melting, it's dripping down right through, which helps relax your pelvic floor. And I get the patients to imagine the coldness and feel the coldness and imagine the lovely mint color coming right down, and it does help them from clenching all the time. So visualization techniques are quite good. There's a lot on the internet about it. You can go read up on it and see, and look for catastrophization of pain. So if they tend to catastrophize their pain, that needs to be addressed. There are questionnaires you can give patients to make them more aware of their catastrophization. You might also send them for counseling, which can help them with catastrophization. So these are things that you can do in terms of giving self-efficacy for patients and getting them to manage to some degree on their own. And my biggest take home is diaphragmatic breathing, because when you do proper diaphragmatic breathing and getting them to do focused diaphragmatic breathing, where they're breathing into their belly to raise their belly up, widen their waist and breathing right into their back passage, it can actually help lengthen your pelvic floor and helps relax your pelvic floor better instead of that constant tightness and hypertonicity in your pelvic floor. There are certain yoga poses like the happy baby pose and the sumo squatting, which are quite helpful in terms of just getting that area more lengthened and stretched, along with a lot of poses that are useful for pelvic girdle pain. So looking at that as an exercise treatment is also useful. And with that, I conclude. Thank you and questions.
Thank you, ma'am, for such a informative session. I can see a lot of questions arising in the chat box. So we'll start with a question and answer session. The first question was, is pain prior to menses or during menses while micturating and defecating due to the hypertonicity of the muscles?
If it is menses, you do need to rule out hormone issues, yeah, because that's more cyclical than non-cyclical, but there is an affection to the pelvic floor muscles, definitely. The issue with cyclical chronic pelvic pain, so if you have anything which is like PCOS or endometriosis or adenomyosis, they can affect pelvic floor muscles. Now, you might also find that you might be having a mixed cyclical chronic pelvic pain. There's a bit of an imbalance of estrogen, where you have a very high rise in estrogen, which is an inflammatory hormone, which then causes hypertonicity in your pelvic floor, and it peaks up around the time of your periods, and you end up having issues with that, okay?
The second question was, is there association between dysmenorrhea and pelvic pain? That is, can dysmenorrhea lead to chronic pelvic pain?
So again, this is a cyclical chronic pelvic pain. It's not non-cyclical. And yes, there is an association with dysmenorrhea and chronic pelvic pain. I can't remember on top of the back of my head who is the researcher who did it, but there are research where they have assessed women with dysmenorrhea and assessed their pelvic floor, and they have found that there's a certain percentage of women who will have hypertonicity or tender points in their pelvic floor, and they also have dysmenorrhea. But it's not that everyone who has dysmenorrhea will have tenderness or hypertonicity. There's a certain percentage. I can't remember that in the back of my head because I did my study for the non-cyclical pelvic pain.
One more question arises. The post-menopausal chronic pelvic pain, is it cyclical or non-cyclical?
Postmenopausal chronic pelvic pain can be hormonal. They might need estrogen. They also need to check their hormones and see if they need to go on HRT, because estrogen is not the only hormone that's depleted during the menopause. You might have a bit of lower testosterone and androgens, and you might need to go onto an HRT to help with that. However, with postmenopausal pelvic floors, considering that there is an obstetric history, getting a pelvic floor review is worth your while, because chances are that you've never had a pelvic floor review. You might have pelvic floor dysfunctions such as a prolapse or bladder or bowel dysfunctions or incontinence. And along with that, you might have pelvic floor pain as well. And many times, unless and until you address the pain issue and then look at bladder, bowel, and incontinence issue, you will not resolve your problems.
The next question was, how to map the pain areas or procedures for mapping pain areas in the perineal region?
So perineal region, there is no mapping because we still don't know if there's a referred pathway for pelvic floors, but we do know that pelvic floors can refer pain to the suprapubic region, lower abdomen, and groin region. If you are doing pain mapping, I would recommend you go along your vertical clock, look at your superficial muscles, look and see if there's tightness or tenderness along the muscles, and then progress onto your deep horizontal clock and look at your deep muscles. And in the horizontal clock, you're going from perineal body at 6 o'clock and coccyx is at 12, and all your other muscles are along that. Yeah. Whereas your vertical clock, your superficial muscles, your perineal body is 6, your urethra is at 12, and all your superficial muscles are along that. So going along the vertical for your superficial muscles and the horizontal for your deep muscles will give you an idea of, are the muscles affected? Applying pressure on those muscles and looking for tender points like you would look for in any of the other muscles of your body can help. Looking and seeing if there's tightness and shortness in the muscles can also help. Pelvic floor examination is like a MSK examination, but you do need to know your anatomy well to know what you're landing on, because it is a blinded approach. You can't see where you're going compared to, say, if you look at piriformis or your sacroiliac ligaments.
So is it true that HRT has been stopped due to the increased number of cases of cancer?
No, there is new research, and it's a very good long-term research that's been done where they have shown that women with HRT had lesser cancer than otherwise. So the concept that women with HRT can get cancer is a very, very old cancer. It has been updated. If you give me 2 minutes, I will find it for you because I have it on my phone. Give me 2 seconds.
Yes.
I'll give you the research name. And I think that needs to be told because you're having a lot of women suffer with perimenopausal and menopausal symptoms, which can be resolved with HRT. HRT is very good for women with regards to bone health. You can get, if they need estrogen, they can get HRT and an estrogen patch, which helps them with bone health. As Asian women, we are more susceptible for osteoporosis than Caucasian women. So for us, getting an estrogen supplement after the age of 45 or an HRT supplement when we hit menopause is beneficial for our bone health and cardiac health. Let me give me 2 seconds and I will get you the research. Do we have time?
Yes, ma'am, we have. Or else you may.
So here's the research. So that they came out saying that estrogen use decreased breast cancer incidence and morbidity. It took 18 years, but finally they have admitted that estrogen doesn't cause breast cancer. The fear mongering is hurting women. So they came out with the data saying that, okay, long-term follow-up shows that there is increased breast risk, but no increased mortality with estrogen and progesterone, decreased risk, cancer risk and mortality with estrogen alone. So giving estrogen alone actually decreased cancer risk and mortality than not giving women HRT at all. Okay, so there is good research on that. There is and I think if you can Google it, this is a new enough research that's come out, and it's a long-term follow-up study, and they found that women who were put on HRT and estrogen were far better off than the women who weren't.
So we'll take the last question. Is it okay to train pelvic floor muscles in children with cough and asthma?
No. Okay, so if they're only having cough and asthma, yeah, and if they are leaking, then you might consider looking at doing pelvic floor training. If they are not leaking, their pelvic floor is working fine, it's able to take the intra-abdominal pressure, don't bother. Okay.
Thank you so much, ma'am. Thank you for all the answers and for such a nice response. Now we are towards the end of today's session. First of all, I'd like to thank all the participants for attending this session with such great enthusiasm. I'd like to extend my sincere thanks to our honorable speaker, Shalini ma'am. Thank you so much, ma'am, for enlightening us with your knowledge and your experience. Thank you for your time from your busy schedule and enlightening us with different aspects of chronic pelvic pain.
Thank you.
I would like to extend my sincere thanks to our Honorable National Head, Dr. Ruchi ma'am, for this venture and for the upliftment of our field. I would love to take this opportunity to extend my thanks to Dr. Suvarna Ganvir ma'am and the entire Maharashtra state team of IAP Women's Cell for their constant guidance, which has actually made this session a success. I thank the technical team of IAP Women's Cell for being the pillars of all these events. And most importantly, I would like to thank each and every person who has directly and indirectly contributed to this webinar. I request you all to kindly share your feedback with us by filling the online feedback form. Thank you all once again.
Thank you. Thank you all.